Oh man, can you hear me? Oh man, can you hear me? Oh man, can you hear me?
God bless you, man. Amen. Amen. Good evening. Good morning, sir.
Good morning.
Sir, how are
Good. How are you?
you? Fine, thank you,
Very-
sir.
Very good. I'm just setting up here.
Oh my God, I can hear my voice. I was talking to my roommate.
Oh, okay.
Good evening. Good morning, sir.
Good morning.
Sir, how are
Good. How are you?
you? Fine, thank you, sir.
Very good. I'm just setting up here.
Oh my God, I can hear my voice. I was talking to my roommate.
Oh, okay.
Good evening. Good morning, sir.
Good morning.
Sir, how are
Good. How are you?
you? Fine, thank you, sir.
Very good. I'm just setting up here.
Oh my God, I can hear my voice. I was talking to my roommate.
Oh, okay.
Good morning, sir.
Good morning.
How are
Good. How are you?
you? Fine, thank you, sir.
Very good. I'm just setting up here.
Can you read that? I was talking to my
Oh, okay.
Good morning, sir. How
Good. How are you?
are you? Fine, thank you, sir.
Very good. I'm just setting up here.
Can you read that? I was talking to my good morning, sir. How are you? Fine, thank you, sir. Can you read that? I was talking to my good morning, sir. How are you? Fine, thank you, sir.
Hello, Dr. Ibrahim.
Hi, this is Dr. Bennett. How you doing?
Oh, hi, Dr. Abawi from Payson, Arizona.
Oh, how you doing?
I'm doing fine. Yeah, I'm.
Let me get. Are you one of Dr. Sabea's guests?
Yes, not guest. Actually, I attend all his meetings. He's a very dear friend of mine, and
Well, welcome.
I admire his work. Yeah.
Yeah, I'm Dr. Bennett. I run this show.
Well, it is really a good meeting. I enjoyed it before.
Yeah, we've had a bunch with Dr. Sabea. As you came to one before, right? There's Dr. Sabea and daughter. How you doing?
Hello.
Hello, good evening, good afternoon.
How are you,
Good
John?
afternoon.
How are you, Dr. Abawi? Jabir, how are you?
Hi, hi, how are you?
Fine. Nice to see you.
Nice to see you. Okay. How are you, Dr. Asil?
I'm good. How are you, doctor?
I'm fine. All right. So,
Thank you for
Yeah.
joining us this evening.
I know you know, every time I do enjoy the meetings with your father. He's genius.
He is. He makes things very hard for me.
No, I mean,
I have big shoes to fill.
I'm sure he will lead you to the right way, to the top of the this science.
Yes, hopefully.
All
Okay,
right.
Dr. Jabir Ahmed. This
Abawi.
is Abawi. So
Yeah,
this
Jabir
Dr. Abawi, he's an associate of Dr. Sabea.
Yeah. Yes.
Ahmed, how you doing? We'll just take this a minute to set up here. Ahmed, I can't hear you. Can't hear you. No audio. Ahmed. Cannot hear. No, cannot hear. I guess you gotta reconnect, maybe. Well, you know what to do. Just play around with it a second. Maybe reboot, Ahmed, reboot, maybe. Turn the computer off and come back in. Oh, you got a smartphone, right? Turn it off and come back in, yeah. Yeah, I don't know if there's a similar phrase in neurosurgery. Things aren't going right, you reboot. Do you reboot in the OR? Just, you kind of stop, let's start over again. You do that? Yeah. It happens with computers all the time. And I find that most problems are solved just by rebooting. Do you notice that?
You hear me now, John?
Okay, there you go. There you go. You got it. And I guess you're not using your camera today, or Ahmed?
Can you hear me
There you
now?
go. Yeah, we can hear you. It's good.
Hi, John. I'm just greeting Professor and Dr. Asil.
Hello, how are you?
Hi, good evening. How are you?
Thank you for inviting us for this.
I'm so excited to see you all.
Thank
Thank you
you.
very much.
Okay,
very
okay,
welcome.
Ahmed, I'll introduce you and you basically run it, right? So
Okay.
you guys, you're both making a presentation, I imagine, right?
Yeah,
Yeah.
the same presentation.
Yeah, okay,
Asil will start first and then I'll
okay, okay. Very good. So did you come to the China one last week, Dr. Sabea?
Yeah, I was with you if you remember.
Yeah, that was great. I tell you, they're gonna do it again Sunday.
so-
Hope you can come.
Surely. Well, it's a
Yeah,
pleasure.
it's at 8, it's at let's see, 8 o'clock China time, which would be around 1 or 2 your time, maybe.
It's
2.
okay. No problem.
Yeah. Yeah, we've got to get a good connection with China.
Absolutely. Absolutely.
Yeah, they have so much talent there that we could learn by. I mean, you guys, I'm sure the world of
Absolutely.
neurosurgery can learn by it.
Absolutely. We learn from each other.
Yeah. You've been to China, right?
Yeah, many times.
Oh, okay. So you know the situation. They
Absolutely.
seem eager. They seem eager.
Absolutely. And with Juha Hernasemini there, he really created a jump.
Yeah. He helped a lot.
Absolutely.
He helped a lot. We had some problems getting translations because he's in the interior of China. As you know, it's
Yes.
not as much English on the interior
Yeah.
of China.
True.
But Ben was good enough to translate every week. Imagine that, Anil, a busy neurosurgeon. Every week he just would translate for Juha.
Yes.
That's
Absolutely.
Amazing.
dedication, huh? That's dedication.
Absolutely.
Yeah, that's really but he knew how much the Chinese neurosurgery community valued Juha. He knew
Yeah.
how much.
Absolutely.
And they call him Yoda there.
Yeah, he's just like a godfather for them.
Yeah, Yoda. I don't know what Yoda did. What did you? Oh man, what did Yoda do in the movie there? He must have been important. He was like an ambassador or something. What was it in the movie? What's it? What was
Star
that movie
Trek?
called? The what? What was the movie called?
I'm not sure.
Yeah.
Was
You
it like
guys-
a Star Trek? One of these
Some,
Star Trek?
man,
Wars,
you
Star
are
Trek,
so
yeah.
far off. You are like 2 generations off. You're worse than me.
Yeah, Star
Oh,
Wars, yeah.
It's like, no, it's past ET. There was Star Trek, but then it was ET. And oh man, you must know what that movie was. Oh man. No, it wasn't ET. It was after ET. But anyways,
No idea.
he was considered a leader. He was considered a leader of the cartoonish character.
But Yoha for China is like Corleone in The Godfather.
Yeah.
Yeah.
They you know, it's funny. He tried to learn Chinese, but I guess it's so difficult that he kind of gave up.
That's one of the most
But
difficult.
how he communicates, I guess everyone likes their OR different. He likes it quiet.
Yeah.
And the Chinese have a chance to talk a lot in the OR, the operating nurses. So he has to make a point of, hey, don't talk so much when I'm operating.
Absolutely.
Well, how do you guys have a preference? I'm sure, right, about ambience of the OR
Well, you know, it depends on
on the case.
on the case and on your mood, actually.
Yeah.
Sometimes I put some music. Sometimes I just hate somebody to move around.
Yeah. Depends on the mood, huh? And the
Yeah.
feeling. Okay. Yeah, I think you all likes it quiet.
I think quiet is the way to go, at least until you are done with the
Major
difficult part of the surgery, and then you can just, you know.
Oh, okay. Then you can put the music on.
Yeah.
John, after Ramadan finishes and the feast of Eid al-Fitr, we'll go back to our 2 weekly webinars as we used to do.
Okay. Yeah, it's kind of a turbulent time. People are just getting their feet in the ground now.
Absolutely.
After the pandemic, they're just starting to, you know, establish a semblance of normalcy.
And it will take time. It will take time.
Yeah, right now there's no restrictions in this country, no masks in public transit. It's pretty well same there.
Yeah. Well,
almost.
Almost.
Yeah.
You don't need to
Yeah.
put a mask in the open places, but you have to put it in the closed places.
Oh, okay. In office buildings and government centers and stuff.
Well, I know many they like music to play during surgery, but I
Yes.
guess it should not be Wagner music. I mean, something really quiet.
Yeah.
Truly.
Wagner will make you go deep. Yeah.
Hammer the head or something.
Yeah, but you know, I've seen a lot of surgeons. They like some mild melody, classic music. Yeah.
And I know you are one of the fans of the classic music.
Oh, I'm really into it for the last 45. You know, when I was in second year in college in Alexandria, there was 2 stations, one for opera and one for classic, and then I hooked ever since. Yeah, I mean, I'm really good at that. Yeah, I enjoyed it.
And I think we have one in common between us, which is Vivaldi and Four Seasons.
Oh yeah, there was an opera. I took my grandkids, not opera. They did it as a ballet forum, and it was really nice. The Arizona Ballet.
Yeah.
All right. Yeah. So, how often you do this? I mean, you used to do it every week, but
yeah, we used to do it every week. Then we shifted to 2 weeks, but then with the Corona thing, it's just lagged a little bit. Now we're coming back.
All right, and you know, there is usually in June there is a Mayo Clinic conference in Sedona, Arizona.
Yes,
Yeah, how about I invite you both to come here?
it's a
Of
pleasure.
course, our pleasure.
Really, yeah. I mean,
Absolutely.
that's yeah. Probably will arrange some meeting here.
It's a pleasure, Jabir.
Thank you.
Okay, all right, yeah.
Fadi Sharbel is there, yes?
Sorry.
Fadi Sharbel, is he there?
No, you know, the one is Dr. Bernard. Not Fadi is the cardiologist, but the neurosurgeon is Dr. Bindak.
Yes, Bandok, yes. Yes.
Bindak, yeah, he's
Yeah.
the one really. He's really the major intervention here in Mayo Clinic.
True.
A couple of minutes.
Where is this nice beach? Where is that?
Miami.
The picture, I know for John Bennett behind your, the background
okay.
is very,
That's
very nice.
Miami Beach. Yeah, let me
Miami.
highlight it here. You've been there,
Miami
right?
Beach, yeah. I've been to Miami Beach to
This is
all kinds.
this is 1 mile away.
Oh, yeah, it's the
Yeah.
Hello, Professor Sabayh.
Hello. How are you?
Good day.
Hi, Asil.
Hello, sir. How are you?
Hi,
good.
my
How are
God.
you?
It's
Well,
been-
this is a surprise.
Long time no see.
Hi, John. How you doing?
How you been?
Long time no see. You
Yeah,
know,
yeah.
I met Asil and with her father Ibrahim some years ago. She was just starting out. My God.
I was a kid.
Yes. Oh my God. It's
You-
unbelievable.
This was the year 2004, Salim, when you
Yes.
came to Jordan.
Yes.
Nasir was
No, we also met in Europe. Remember when Sami invited what year was that? When we were
it
in
was
Europe?
2009, and it was in Prague, in Czechoslovakia.
Yes. That's what I remember because you had the whole family with you, and I remember
Yes.
Asil was there. What stage were you in at that time, Asil?
2009, I was in the second year of medical school.
Yes.
I was just starting out, finding my way.
And remember, we had this boat trip on the River Charles.
Yes, I remember that.
There
Yeah,
was
yeah,
the football
A game.
games,
Yes.
which you, I, and Majid Sami attended, and my son
Yes.
Aziz was explaining, and you
Yeah.
thought he knows a lot about the players and so on.
Yeah. That is great. It's so good to see you. So proud of you, Asil. My God, that
Thank
is
you,
great.
sir. Thank you.
Yes.
Thank you very much. It means it means a lot that you are here with us.
No.
Thank
This is great. We are so proud.
Thank
Proud
you.
of you.
Thank you very much. Thank you.
Yeah, this is great.
Hi, Professor Salim. Can you hear me?
Yes. Who's this?
I'm
Is
so
it
excited
Ahmed?
to see you here.
Ahmed.
Oh, okay. Great, Ahmed. How you doing?
I'm doing very well. About you, sir?
Hey, Ahmed, why don't we do this? Why don't we let Salim introduce the Sabayah? Seems to know him well.
I'm gonna, John. I'm gonna say a few words and let Ahmed read off because Professor Sabayh has a lot of titles. Let Ahmed say those. I'm gonna say a few introductory words and then have Ahmed officially introduce him.
Okay.
Yeah. Whenever.
Should I start first after John?
Yeah. Why don't you go first? Then I'm gonna say a few words and then we start the lecture.
Okay.
Okay, that sounds like a plan. Algonomy. Okay, here we go. Ahmed, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good afternoon from Miami Beach. We have another in the episode, Walter Dandy of Yemen. And let me introduce Ahmed Al-Ghanami, who's going to introduce the players. Hello, Ahmed.
Hi, thank you, John. First of all, I would like to congratulate all Muslims around the world on blessed and spiritual months. شهركم مبارك ودعمتم بألف خير. Honestly, it is so hard to express in words the gratitude, happiness, and the honor for hosting the first, the number one neurosurgeon in skull-based surgeries in the Middle East and in the Arab world, Professor Ibrahim Sbeh, who was the vice president of the World Federation of Neurosurgical Societies and the president of the Yemen Arab Neurosurgical Society twice, in association with the amazing and great neurosurgeon, Dr. Asil, who is a neurosurgeon in Farah Medical Campus. Hi, all.
Hello, thank you for the introduction.
Great. I wanted to say a couple words in my capacity as a global president of the Dengue Society, but at a personal level, it is an honor to host Professor Sabayh. He has been a pioneer in the region of the Middle East as an educator and at the global level, actually, to be an educator for a generation of neurosurgeons. So his contributions are numerous. He has played a large number of executive roles in the leadership in the field of neurosurgery. I've known him for many years. He invited me to Jordan. I had a great time to meet him there. And actually, I was just talking to his daughter, Asil, who is a neurosurgeon. I remember meeting her in one of the trips when Professor Sabayh and I were lecturing in Europe, and she was just starting medical school. So it is with tremendous pride that we see her today as a neurosurgeon, as a consultant neurosurgeon. And it's this exactly is the model that we are trying to mentor the young people around the world with. We have students all over the world now. We have over 52 clubs in 52 countries of the next generation of neurosurgery, those who are going to become neurosurgeons. Asil is exactly, it's what makes us proud. What makes us proud, and this lecture means a lot to me because seeing her here and having her give a talk with us, it really is what we all seek. So this is great and an honor to be with you all. Thank you.
Thank you, Salim.
Thank you, sir. Thank you very much.
So I think you start.
Okay, so we'll start our presentation for the night. Let me share my screen with you. So again, good evening. Hello from the beautiful Amman, capital of Jordan. Today we'll be talking about the anatomical basics of skull-based surgery. Our area of interest would be the sphenoid bone and the anterior clinoid process. Again, my name is Asil Sbeh. I'm a board-eligible neurosurgeon working in Farah Medical Campus in Amman, Jordan. Just a preview of where I work. This is the hospital where I work, one of the most prestigious private hospitals in Amman, Jordan. And as a proud Jordanian, I would love to take any chance and any platform to talk about my country for a little bit, if you allow me. So this is the capital of Jordan, Amman. This is the new downtown. This is the Temple of Hercules. This is old downtown where we have the Roman theater, which can take up to 6,000 spectators, and it's a site for major events in the kingdom. Going south, we have Petra, one of the recognized UNESCO World Heritage Sites. It's a marvel, to be honest. If you ever come to Jordan, you should visit Petra. Wadi Rum, it's a beautiful place where you can go mountain climbing, you can go camping under the stars, you can go hot balloon air rides. It's just beautiful. We have Aqaba at the Red Sea where you can go scuba diving. And we have the Dead Sea, the lowest point on Earth at 420 meters below sea level. And we have a lot of health resorts there where you can just enjoy and, have a good time. We have also the baptism site at the River Jordan, which was sanctioned by the Pope at his during his Holy Land tour in the 2000. We have Jerash, one of the most well-preserved Roman architecture outside of Italy. It's amazing there. And we have there also the Roman amphitheater, where we have an annual music festival. The countryside of Jordan, as you can see, is just amazing. A lot of hikers and adventurers would like to go there. And this led to the establishment of the Jordan Trail in the 2015, where you can go from the northmost part of Jordan, Qais, to the southmost part at the Red Sea in 40 days, covering 600 plus kilometers, enjoying the history and culture of Jordan. And finally, this is the iris, the black iris, the symbol of Jordan. Now let's go to our topic of the day, the sphenoid bone. The sphenoid bone is a central bone in the cranium. It articulates with many bones, as we will see now. So looking at it anteriorly, we can see its articulation with the frontal bone and with the zygoma and with the ethmoid, and we can appreciate it's forming the lateral part of the orbit. Looking from a superior point of view, this is the sphenoid bone. It takes the shape of a butterfly, and actually sphenoid, translating from Latin, means a wedge. So it actually looks a kind of like a wedge. And it's, as we said, it's a central part in the cranium, articulating with the frontal bone anteriorly and the ethmoid, with the temporal bone and with the occipital bone behind, forming the clivus. Looking sideways, it's part of the pterion, which gives name to the pterional approach. We will be talking about it. And here we can say the articulation with the frontal bone and with the ethmoid and with the zygoma. And looking from below, we can see the articulation with the vomer bone and with the palatine bone, and as well as the temporal bones. Again, looking anteriorly and appreciating the association with the ethmoid bone and with the palatine bones here. Now let's focus more on the sphenoid bone per se. As again, we said it's a butterfly-shaped bone and it has many parts. The first part is the body of the sphenoid bone. It takes a cubical shape. It hosts the sphenoid sinus, which is, it's not well formed at birth, and it grows with the growth of the skull and until after the person reaches puberty. We have the lesser bones, two lesser bones, lesser wings. We have the greater wings. We have the pterygoid processes, the medial one and the lateral one. And we can see here the superior orbital fissure, which is a slit-like gap between the greater wing and the lesser wing. We can see the sphenoid ostium here. We can see the foramen rotundum and the Vidian canal, which hosts the Vidian artery and nerve going to pterygopalatine fossa. The greater wing of the sphenoid is the origin of the temporalis muscle, and the medial pterygoid process is the posterior part of the nasal cavity. The lateral pterygoid process is the origin of the lateral and medial pterygoid muscle. So we can see it's a complex association with these surrounding structures. Again, we can see here the lesser wings, the greater wings, the superior orbital fissure, the optic canal here, which is part of the lesser wing, and we can see the optic strut, which is a bony landmark going from the lesser wing towards the body of the sphenoid, and it separates the optic canal from the superior orbital fissure. Again, we can see foramen rotundum here and the Vidian canal and the pterygoid plates. Looking at this as the sphenoid bone from posteriorly, again, the lesser wings, the optic canal here, the anterior clinoid here, the dorsum celli with the posterior clinoids. We can see the superior orbital fissure, foramen rotundum, Vidian canal, and the pterygoid plates. And here is the articulation of the sphenoid bone with the occipital bone. Now, looking from the superior point of view, so we can appreciate the parts of the body of the sphenoid even more. We have here the planum sphenoidale, which is the smooth part of the sphenoid. We have the tuberculum cilli. We have the anterior clinoid processes, which are part of the lesser wing. We have the hypophyseal fossa, or the sella turcica, which hosts the pituitary gland. We have the dorsum cilli with the posterior clinoid processes projecting from it.
Asil, we cannot see the slide when you're speaking, so I just want to make sure you're sharing the slide, because when you're last few minutes you're speaking, I don't see the slide.
Okay, I will stop the share and I'll share it again.
Please, please.
Yeah. Can you see it now?
Yes, perfect.
Okay.
Mhm.
Do I need to go back, or is that okay?
I think we're okay. We're okay.
Okay. So again, looking at the sphenoid bone from superiorly, we can appreciate the articulation with the frontal bone here, with the ethmoid, with the crista galli. We can see the optic canals, and we can see the anterior clinoids here, the sella turcica or the hypophyseal fossa, the dorsum cilli with the posterior clinoid. A zoomed in view, again, the lesser wing with the anterior clinoid process part of the lesser wing, and we can see the optic canal here, the optic struct going from the lesser wing towards the sphenoid bone, the planum, the optic canal here at the other side, the sella turcica and the dorsum cilli with the posterior clinoids here. The chiasmatic groove is a part of the body of the sphenoid, and it's pressed here, and this is where obviously the optic chiasm is. Optic canals here, and we can appreciate that the optic canals are medial to the anterior clinoid process, an association we should keep in mind as we go on. Again, optic canal, anterior clinoid process, superior orbital fissure, and the optic struct separating the optic canal from the superior orbital fissure. Now, the anterior clinoid process and the posterior clinoid process are consistent part of the anatomy, unlike the middle clinoid process, which is not a consistent component of the anatomy. We can see a variation even when it comes to males and females, so it's more common in females, and it's more likely to be pneumatized. And its importance comes when we talk about endoscopic approaches to the skull base, because it hinders the exposure. So we should keep in mind about the medial clinoid process. So it can only be a projection from the body, or it can form a complete ring around the carotid. So it does have variations that we should keep in mind. Now we're looking at the sphenoid bone from an oblique point of view. So here we can see the greater sphenoid wing. We can see the lesser sphenoid wing with the anterior clinoid process. This is the superior orbital fissure, the posterior clinoid process, the posterior clinoid process on the other side, the anterior clinoid, and the optic canal on the other side. Same view, different picture. And of course, we should keep in mind how the optic canal and the superior orbital fissure look from inside the orbit. So we're looking at the right orbit from the anterior point of view. This is the optic canal, this is the optic strut, this is the superior orbital fissure, inferior orbital fissure, and this is the anterior clinoid. A zoomed in picture, optic canal, superior orbital fissure, optic strut, and the anterior clinoid process. Having reached there, we can mention annulus of Zinn, which is the tendinous origin of the extraocular muscles. It contains within it the optic canal with the optic nerve and the ophthalmic artery, and goes through with the superior and inferior divisions of third nerve, abducent nerve, and nasociliary nerve. Now to talk about the anterior clinoid in more detail. Again, it's part of the lesser wing of the sphenoid bone. It is the most medial part of the lesser wing of the sphenoid bone. And again, the optic nerve and the carotid are medial to it. Here we can see the anterior clinoid, and it's covered with dura, the optic nerve, the internal carotid artery, third nerve. going a little bit laterally, we can see its relation to the roof of the cavernous sinus. It's a small anatomical landmark, but it does have parts that we should be aware of because it comes in handy when we do any approach concerning the anterior clinoid. So we have here the tip, the head, the body, and the base. And we should know that drilling of the anterior clinoid process, each pathology dictates the margin to where we should drill. So we should keep that also in mind. This is a picture of the anterior clinoid process completely nomatized, and this brings us to the classification of the anterior clinoid process according to the nomatization. So we have this paper talking about the anterior clinoid process. We have 4 types of nomatization. Type 0, which is the most common, and the anterior clinoid process is completely solid. It has no nomatization. Type 1, where the optic strut only is nomatized or less than 50% of the volume of the anterior clinoid. Type 2, more than 50%, less than 100%. And type 3, where the anterior clinoid process is totally nomatized, and this is the least common part. And this should be kept in mind when we drill the anterior clinoid process, because nomatization of the clinoid process means we have to pack it in order not to have CSF leak or meningitis post-op. The anterior clinoid process have a very close relation to the internal carotid artery, specifically C5 segment. So we should keep that in mind. So this is C4, this is C5. The anterior clinoid part is below the C5 and above the C4 parts of the internal carotid. Here we can see the relationship to the ophthalmic artery, which originates from the dorsum part of the internal carotid. So we have the internal carotid and the ophthalmic artery in close proximity to the anterior clinoid process. And here we have the carotid cave, which is the most medial part of the internal carotid. And we should keep in mind that the ophthalmic artery has many variations regarding origin, so it can originate as normal from the dorsum part of the internal carotid before the dural ring or after it, or it can completely originate outside this area from C4 segment and go into the superior orbital fissure, bypassing the optic canal. We're talking arteries, now we have to talk veins. Pterional approach going into the anterior clinoid, we should keep in mind the important venous anatomy there, the most important of which is the sphenoparietal sinus going into the cavernous sinus. And any injury to these veins could result in major venous infarct. So sphenoparietal sinus, we have the superior ophthalmic vein, we have the middle meningeal vein, we have the superficial middle cerebral vein, all going into the cavernous sinus. We should keep in mind, because as we go there, we can find them. They are in our way there. So we should keep in mind this anatomy and be aware not to coagulate these veins. This is an venogram showing the sphenoparietal sinus going into the cavernous sinus. Dural rings, we have the distal ring and we have the proximal wing. The distal ring should be cut when we deal with, after drilling of the anterior clinoid, to make the mobilization of the carotid artery easier. So we should keep that in mind. Again, the distal ring, the proximal ring, and we have the carotid collar also here. We should keep that in mind. And the optic strut here, we have drilled the anterior clinoid and we have the optic strut left, which also should be taken out as we go. This is an endoscopic view showing the optic nerves, optic chiasm. Here we have the distal ring, here we have the proximal ring, and here we have the carotid cave. The anterior clinoid to the optic nerve is, as we said, the optic nerve is medial to the anterior clinoid process. We should keep that in mind. We have here the falciform ligament covering the optic nerve as it goes into the optic canal, which should be cut as we deal with any pathology in this area. Optic nerve, falciform ligament, anterior clinoid process. This is the internal carotid, and this is the lesser wing forming the anterior clinoid process. And here again is the roof of the cavernous sinus, which are all in proximity to the anterior clinoid process, as we can see. Again, anterior clinoid, optic nerve, internal carotid. This is third nerve, fourth nerve, V1 going into the superior orbital fissure, and V2. All of these are in proximity to anterior clinoid process. And here again, optic nerve, chiasm, internal carotid, posterior clinoid, and here there's the third nerve going into the superior orbital fissure. Lastly, the cavernous sinus. Any approach going into the to the anterior clinoid process can help us go to the lateral wall of the cavernous sinus. So here is the lateral wall of the cavernous sinus. We have drilled the anterior clinoid. In order to get there, we have some landmarks that we should keep in mind. One of which, the most important of which, is the meningoorbital band, which attaches to the lateral part of the superior orbital fissure. So if we get there, we know that we are very close to the anterior clinoid process. We should dissect this meningoorbital band so we can have better exposure of the anterior clinoid and the cavernous sinus. So here we can see a meningoorbital band, artery, and vein going in this area. Dissection, we can have better exposure of the anterior clinoid as we drill. This is an extradural approach. And after we have dissected the meningoorbital band and we reach this area of interest, this is the superior orbital fissure. This is the optic nerve. We can see V1 going into, and this is the anatomy that we need to see after going to that area. Radiology, last, just a couple of CT scans showing normal anatomy. So this is the anterior clinoid part. This is type 0. As we said, this is the most common, completely solid, no pneumatization. This is a pneumatized anterior clinoid process. This is how the superior orbital fissure looks like on the CT. Superior orbital fissure, this is the optic strut, anterior clinoid process. This is solid, and the greater wing of sphenoid. This is a coronal view. So we have anterior clinoid processes here and here. We have optic strut here. We have the optic canal, and we have the sphenoid sinus. Completely pneumatized anterior clinoid process. So we can now imagine that if we drill this and not pack it, this could easily end up with CSF leak post-op. Anterior clinoid, optic canal. This is optic strut and superior orbital fissure. And interestingly, now there has been some papers talking about the shapes of the optic canals. These are in the pediatric age group. So we have different shapes of the optic canal. And I have mentioned this so we can just keep in mind that this area is complex. It's still under research and a lot of more papers to talk about it. And thank you. Now we go to Dr. Spey, who will talk about the pathology in this area. Thank you. Can you see the slides?
Yes, we can. Thank you.
Yeah, thank you.
Right. Thank you, Asil, and again, thank you, John. Thank you, the Andy Society, and I'm really pleased and thrilled to see Salim on the room with us today. He's a family member, he's a close friend, he's a real brother to me. I will just continue where Asil stopped, and I'll speak about the anterior clinoid process. Asil just mentioned that it is the most medial part of the laser wing of sphenoid. And as you can see, this is the anterior clinoid, this is the optic strut, and so the superior orbital fissure is here, and the optic canal is there. So what are the pathologies that we can meet if we are dealing with anterior clinoid process? Some of the slides I'm showing, or some of the pictures, are my cases, or some are from Anne Osborne book. So these are my cases of fibrous dysplasia affecting the anterior clinoid process and the sphenoid bone. Sphenoorbital meningioma in one of my patients from Iraq. Hemangiopericytoma, just like a meningioma, can occur there. intraorbital meningioma that passes through the optic canal, so you have to deal with the anterior clinoid process. Optic nerve glioma, which could be totally inside the orbit or within the canal or extending to the optic chiasm intracranially. Case of mine with the orbital apex cavernoma, just sitting in the orbital apex, 38-year-old female. Metastasis can affect the sphenoid and affect the anterior clinoid in particular. Paragangliomas, chondrosarcoma extending into the anterior clinoid, angiofibroma also extending there. Schwannoma of oculomotor nerve, although very rare, yet you can come across these cases. And in this very particular case of mine, this patient has a very large pituitary adenoma, which was extending through the optic canal into the orbit. Of course, if you are dealing with ophthalmic artery aneurysm or the aneurysm which is just underneath the anterior clinoid, then obviously you have to drill that and you have to cut the rings around the carotid so that you can mobilize it and clip the aneurysm. And another pathology is the anterior clinoid meningioma, which I will take tonight as an example of the anatomy that Dr. Asil has mentioned and apply it on the surgical approaches for these skull-based surgery approaches. So my talk is about anterior clinoidal meningiomas, and I'll talk about clinical, radiological, operative, and pathological correlation. When we say anterior clinoid meningiomas, we mean a meningioma arising in the vicinity of the anterior clinoid process, and they constitute about 10% of all intracranial meningiomas. So in this very critical situation, you can see that it can really involve so many structures, and it can be really very difficult to treat. We have to remember a very important association with the clinoidal meningiomas, that is aneurysm occurring in 0.5% of cases. Some of the papers from China mentioning multiple intracranial aneurysm in association with the clinoidal meningioma. Another paper from Pakistan showing this association, and a bilateral intracranial aneurysm also reported with these anterior clinoid meningiomas. So always be aware and always insist on getting a very good view of the arteries and veins there. Presentation, as we'd expect, some headaches, but mainly visual. Actually depends on the extension of the tumor. Are you going to the orbit, or are you going to the cavernous sinus, going to the temporal lobe, so you can get epilepsy, and even the posterior fossa, you can get midbrain hemiparesis. The blood supply of these meningiomas, as Dr. Asil mentioned, is coming from the middle meningeal or accessory meningeal, from the artery of the meningioorbital band, from the posterior ethmoidal artery, a branch of the ophthalmic artery, or directly from the ophthalmic artery, or from the bifurcation of the internal carotid. Some of the pictures here for the blood supply of these meningiomas. So at the end of the day, this is a complex anatomy. This is a complex pathology involving these important structures here. And as I mentioned, the meningioma of the anterior clinoid can extend into the medial sphenoid wing, paracellular, cavernous sinus, posterior clinoid, petroclival region, middle fossa, and posterior fossa. The problem is that when they are large in size, you would have difficulty deciding where is the exact origin of these tumors. And when they extend into the surrounding structures. A very important extension to us as a neurosurgeon is extension to the optic canal, which raises the question, do we need or do we not need to drill and open the optic canal? So they can go anywhere to optic canal, severe orbital fissure, to the cavernous sinus, everywhere. The problem with anterior clinoid meningioma is that there are few published series, and there is only 3 series that include more than 100 patients. So we need more of publications on this and this pathology so that we know more about these ones. This is some of the papers published, Al-Mufti, but the 3 major ones, Nakamura, Leo, and by Hisham Basuni. If you look at the number of cases, 34, 33, 15, 26, so almost small number of cases. The only large series that contain more than 100 are only 3 series. First series is from Nakamura, published 2006, 108 patients, getting gross total resection in 43% with recurrence of 10%. So this is the problem with these tumors. You cannot get always a good gross total resection, and the recurrence rate is high. Another series which contain more than 100 patients are from Hisham Batsuni from Germany, published 2009, 106 patients with a gross total resection 58% and recurrence 25%. This is a high percentage of recurrence. Third series from China, Ming Zhang, 2020, gross total resection 67%, recurrence in 11%. Another major series is the one from my friend Felix Szymanski of Israel, reporting 22 patients with giant anterior clinoid meningiomas, and he could achieve gross total resection in only 30.4%. Another patient from the leader of vascular neurosurgery, Juha Hansemini from Finland, who is now working in China, 73 patients. Another patient from another series from South Korea, 59 patients, and they showed what are the non-favorable prognostic factors. The large size is not a good prognostic factor. The internal feeders, the high grade of the meningioma, and the old patients. These are all bad prognostic factors. The classification of anterior clinoid meningiomas, so many, although the cases are not many, but the classifications are variable. Sam al-Mifti back in 90, Atul Gul 2000, John 2 2004, Nismetin Pamer from Turkey 2008, Hisham Batsuni from Germany 2009, Tao XU from China 2009, Anil Nanda 2016. Let's look at this. Clinoidal meningioma, according to al-Mifti, they classified them into type 1, type 2, type 3. As you can see, type 1 is medial part of the anterior clinoid, type 2 is the lateral part, and group 3 or type 3 is at the origin of the optic canal. So you can see that this is group 1, and group 2, and group 3. As you can see here, let's look at them closely. So this is type 1, and you can see type 1 is the most difficult to achieve excision because there is no plane of equilibrium between the adventitia of the artery and the tumor itself. Type 2, you can see there is some plane of equilibrium here, and then type 3. Al-Mifti classification is widely accepted, but the drawbacks is that distinction between various groups is not always possible because for large size. So in most cases, you would decide the origin of the tumor intraoperative. Atul classification is very reasonable, and it is simple and to the point. He just looked at the internal carotid artery. Are you displacing the carotid artery, the ipsilateral carotid, or you are encasing it without narrowing it, or you are encasing and narrowing it, or you are even going to the contralateral carotid? So here we are. Type 1 or type A, you are just displacing the carotid. Here you are surrounding the carotid, but you have not causing narrowing. Here you have surrounded it, but caused narrowing. Here you have crossed to the other side. So just examples of these classification of Atul. Type A, as you can see, the artery is just displaced. Type B, the artery is surrounded but not encased. Type C is surrounded by and encased and narrowed. Type 4, you have narrowed completely and pushed to the other side. You may even reach to the basilar artery. John 2 and Van Loveren from Florida, and John 2 from Cincinnati published this paper 2004, and they just looked at this. They said this is the true clinoidal meningiomas. If it goes like this here, this is called the spheno-cavernous. If it takes a larger size like this, this is clinoidocavernous. This is, as we said, the goal. Sorry. Another classification by Nismetir Pamir, my friend from Turkey, is just the same like Al-Mifti group 1, group 2, 3, medial part, lateral part, close to the optic canal, but he added the size. So he would say group 1 would be type A or B or C according to the size. Group 2 also could be this size or this size or that size. So he combined the location with the size. Hisham al-Basuni with the large series, more than 100 patients from Germany, he looked on where the tumor is going. Is it going medially or laterally or backwards, going to the optic canal. Tao from China also classified them into 4 types: medial part, lateral part, the tip, and the most medial part here going to the optic canal, almost like Al-Mifti. So this is type 1. You are on the superficial surface of the anterior clinoid process. This is the easiest type. The lateral surface is again another easy type. 2A and 2B, tip of the anterior clinoid. If you are involving the medial surface, this is type 3. And if you cannot define the origin, this is type 4. Anil Nanda looked at how much of the anterior clinoid process length is involved. If we look at all these series and look at the overall gross total resection, it's something like 64%. And the recurrence is still high, 4 to 26%. These are the papers, number of patients and the different authors, and the rate of gross total resection and subtotal resection. Again here, the authors and the recurrence rate. And here, looking at the visual outcome and different studies, whether the vision has deteriorated or stayed as it is or improved. So, in summary, recovery of the visual function after surgery is observed in 48% of patients only. That's why when you are working or doing a case of anterior clinoid meningioma, you have to discuss this with your patient in details. Mortality in general of these cases, some of the series in Al-Mifti series, it was 2 cases out of 24, and so on and so forth. So these are formidable, challenging cases. Now I'm going to tell you about my personal experience with these cases. I had the experience of operating on 60 patients, but the full follow-up of these patients was achieved in 42 cases. And this is what I'm presenting. I would not present a case in which I had done the surgery, but there was no long follow-up. So the tumors extending to the clinoid region are not considered. So if there is a tumor of the planum sphenoidale extending into the anterior clinoid, I would not include it. So these are pure anterior clinoid meningiomas. As we'd expect, females more, peak age 40 to 50. And the main presentation, as we said, is visual dysfunction or headaches. Of course, you can get cognitive problems, seizures, etc. In every case of anterior clinoid meningioma, we do full ophthalmic assessment in details: visual acuity, visual fields, fundoscopy, optic OCT, and exophthalmos measurement. And we use the German score that is combining the visual acuity with the visual field. It's more accurate than just looking at the visual acuity alone, visual field alone. Fundoscopy, of course, is essential. Optic OCT to see whether you have optic atrophy or not. And sometimes you may need to do a visual evoked responses. And in every patient of mine doing skull base surgery, I subject them to have full psychological assessment, including Karnofsky Performance Scale. I choose some of the images from my series. I'll show you some of the CT scans in my series. You can see here the anterior clinoid is destroyed, and here the severe orbital fissure is widened. Again, these cases are all from my series. You can see calcification. You can see calcification in the sagittal view. You can see hyperostosis, which means a tumor. We stopped using the term hyperostosis. Hyperostosis means a tumor. So if the anterior clinoid is hyperostotic, there is a tumor there. Again, different kinds of involvement of the anterior clinoid in my series. And the pneumatization, which is essential to know because you will need to drill the anterior clinoid. And most importantly, that you can compare the preoperative with the postoperative. So here, in this particular case of mine, the anterior clinoid was drilled and the optic canal was opened. So you could see that you have done a good job there. Images of MRI, ranging from small case, small size case to large cases. And I have to tell you, in this part of the world, we get them in giant sizes. So this is all the cases in large size, which I deal with in this part of the world. And you can use the Fiesta sequence to see the relationship with the optic nerve and the apex of the orbit. You have to see on MRI whether there is any optic canal involvement. Sometimes you don't see it on radiology, but intraoperatively you see it, but try to see it before you go in. So in this particular case, there is involvement of the optic canal. Cavernous sinus is involved in 1/3 of the clinoidal meningioma. And if you have a case where you cannot define this is a true intracavernous or extracavernous. If 2/3 of the tumor are outside, it is a clinoidal. MRA, MRV are essential. You can see here elevation of the middle cerebral. Angiography is essential. And here, this is the MRI angiography. You can see here we are looking at the ophthalmic artery, which you see it here on normal side. On the other side, you don't see it. And again, one of my cases, a 58-year-old professor of English language in the university, had this extensive tumor causing this stretching and narrowing of the artery. You can see the blush. And you can see the superficial middle cerebral vein and the sphenoparietal sinus draining into the cavernous sinus. A very beautiful paper here is the relationship of the veins, because if you are using the Sylvian approach, the trigonal approach, then you will come across these veins that are hidden underneath the clinoidal meningioma. You have to know where they are draining. And this beautiful paper shows these tumors here. This is the tumor. The veins are draining into the cavernous sinus. Here they are draining into the sphenoparietal basal sinus. Here they are going to the sphenoparietal sinus. So very accurate anatomical knowledge about the arteries and the veins is essential. The treatment of these cases, and I'm talking about my series, I've never used embolization for this anterior clinoidal meningioma, and there is a reason for this. An interventional radiologist would not like to do it because they are afraid of causing damage to the or closure of the ophthalmic artery, which is a serious thing. Endoscopy has gained a good reputation recently, but not for the anterior clinoidal meningiomas. I still think in infancy. Endoscopy is the future of neurosurgery, but endoscopy for anterior clinoid is still in infancy. Some of the papers published on endoscopic endonasal resection of the anterior skull base meningiomas. Radiosurgery. I would never use radiosurgery upfront for my cases, though we were the first country in the Middle East to acquire gamma knife back in '96, and this is me treating the very first patient then. But we have a solid agreement that gamma knife is radiation and should not be used haphazardly. You should use it for the good indication. It's a good tool, but should be properly used. So I've never used an upfront radiosurgery for anterior clinoid meningioma. I only use it for patients who were deemed unfit for surgery or when I leave a residual tumor after surgery. And that must have conditions, that there should be no contact of the residual tumor with the optic apparatus, and you have to remember the risk of pituitary dysfunction. So all in all, I think gamma knife is a good tool, but has been abused all over the world. I use it very cautiously and in a very limited indications. And sometimes when you do surgery and you have to leave a residual tumor, this paper, very beautiful paper, show that you can put a fatty graft to separate the optic nerve from the residual tumor. Having said that, some people would advocate gamma knife. This is from Dave Lansford in the States with Kondziolka and so on, his team, and they reported this gamma knife stereotactic treatment for cavernous sinus meningioma, including the anterior clinoid meningioma. They reported 200 patients. They had 16 tumor regression. They have 24 unchanged, 15% increase in spite of the gamma knife. And the problem here is these 2 points. If they increase after gamma knife and you have to go for surgery again, surgery is definitely 100% much more difficult. So I have to think twice before giving gamma knife for these cases. And remember that because of the close proximity to the clinical nerves, especially the optic nerve, there is high complication rate there. Another paper from Jason Sheehan from the States, including multi-center studies, 12 centers, 207 patients, either radiologically suspected or histologically confirmed. I agree with the histologically confirmed, but would you give radiation for a lesion that has been histologically verified? I would not. And they had 7% tumor progression and 8% visual deterioration. So we come to the golden treatment, which is the surgical excision, though we have to know this is formidable, challenging cases. And I do believe strongly that meningioma surgery in this region is highly a technical job. It depends on the surgeon expertise and knowledge. So surgery there is associated, as we have seen, cervical morbidity and recurrence. And this is totally agreed in the skull-based community, skull-based surgery community, that anterior clinoid are second only to petroclival meningiomas in their difficulty. Many approaches, perional, subfrontal, you name it. Part of the surgery, I believe, is a clinoidectomy, which in my case, in almost all cases, especially except in very, very small cases, the clinoidectomy could be minimal, could be partial, could be total, as Cecile explained. This is a large structure. People think of anterior clinoid as a small structure. It is a large structure of tip and head and body and base and so on. You can use for drilling the sonopet, you can use the drill, macro, and the rongeur. There has been report on using sonopet of causing damage to the optic nerve. You can do the drilling either extradurally, intradurenally. You can use it as routine in all cases or in selected cases. And if you look into the history, Charles Drake was the first who was done anterior clinoidectomy. Charles Drake, by the way, late Charles Drake, visited us in Jordan back in 1993. And I remember taking him around Man and Jarash and all the historical sites of Jordan. He was so pleasant man with his wife. Greatly appreciate that period of time that he spent with us. Yazergil used it in 1977. Vinko Dollens used it in 85. So intradural or extradural, hybrid, as I said, high-speed drill, ultrasonic aspirator. And recently, some people are not using the drill at all, no drill technique. So we can have partial clinoidectomy. You can have complete clinoidectomy, according to the pathology you are dealing with. Again, remember, the anterior clinoid is a large structure. It is not a small structure. And the connection between the anterior clinoid tip and the body of the sphenoid is the optic structure. So you have to continue drilling until it is completely thinned out, and then you can take it out. Here you are looking at the roof of the cavernous sinus. in the clinoidal segment of the carotid. The value of the anterior clinoidectomy is very well established. Anterior clinoidectomy, opening the canal using ultrasonic bone curette. And here is the total clinoidectomy in block removal of the anterior clinoid process. And here, the line of cuts if you want to do total clinoidectomy. Some people are with anterior clinoidectomy. These are called proponents, and some people are against it. Let's look at why people advise clinoidectomy. Because there is bone invasion in 25% or more. You can achieve good gross total resection. You can have a better visual result, and you can have less recurrence. So the advantages are there, and they are strong advantages. Papers by Said in the United States, 2008, high incidence of optic canal involvement. It's not 16%, it's not 20%. In this paper, it's much more than that. And also in the paper of Sam al-Mifti. 2013, impact of anterior clinoidectomy on visual function. The conclusion that it has impact on better visual outcome. From USA 2015, from Michael McDermott, who is a meningioma man in San Francisco. We've met in skull-based surgery meetings. Meningiomas of the anterior clinoid. Is it wise to drill on the optic canal? The answer in this paper is strongly yes. Another paper from 2018 about the anterior clinoid meningioma resection using ultra-optic canal drilling. Ultra from Japan. The people who are against anterior clinoidectomy, they say, why should you bother? It will increase the time of surgery. You may have complications for the nerves and the vessels. You may have CSF leak, so don't bother, don't do it. I'm against that. I am a proponent and advise the anterior clinoidectomy. And this is a new paper, 2020 from USA, about surgical resection of a clinoid without a clinoidectomy. And they show some of their results, 29 patients in this paper. 26 were done without clinoidectomy, and they claim to have got 76% of gross total resection. My experience, again, the 60 cases I operated upon with the 42 cases with long-term follow-up, I use the carinal approach most common, 27 out of the 42. I've achieved Simpson grade 1 to 2 in 22 cases, Simpson grade 3, 17 cases, Simpson grade 4 in 3 cases. And the average follow-up of my cases is 64 months, ranging from 24 months to 127 months. I followed them up, and I found that there was no residual tumor in 22 cases out of 42. In 20, there was residual. What do? You jump on them, giving radiation? The answer is no. You follow them up. I followed them up. And I just found progression on only 4. So observation first, and if they progress after that, then you can go again for surgery or for gamma knife. I've never used gamma knife upfront. Visual outcome in my series, 26 improved. Static 14, worsened 2. Why did they not improve, the static ones? Because there was so much pressure on the blood vessels, the tiny, tenacious blood vessels of the optic apparatus. Complications of mine, luckily I had no mortality. About the morbidity is like any other series, CSF leak, wound infection, epilepsy, etc. This is one of my cases with CSF leak after anterior clinoidal meningioma excision. We published our findings, myself and Dr. Abu Farsakh, histopathologist. What are the predictive markers for meningioma grading? We looked at the 300 or 250 consecutive cases of skull-based meningiomas. And we came that the higher the KI, the worse prognosis, the higher P53, the worse, and the lower progesterone is the worst. So these are the prognostic factors in our study, which was published in the American Journal of Pathology. So here we are, P53, the higher ones, like 7 and grade 3. And again, P63, same thing, the higher ones in the grade 3. And progesterone is the same. And Ki67 like 23.5% in grade 3. So we came to the conclusion, like in males, the high grade in grade 2 and 3 are more in males, while grade 1 is more in females. Some of my illustrative cases of my series, this 55-year-old female patient with this meningioma that has caused lots of edema. She came from Iraq with visual deterioration, and this is her post-operative and follow-up. Another 45-year-old female patient with this anterior clinoidal meningioma, before and after. 60-year-old female patient with this meningioma. This very large, giant anterior clinoid meningioma, pre and post. Another 52-year-old female patient, before and after surgery and follow-up. 59-year-old female with this tumor. 40-year-old female patient with this very horrendous tumor. You can see the internal carotid and bifurcation inside. So when you look at this, you say, this is formidable. I just cannot do anything. But you will go there, be patient, try to find the plane of cleavage, and you'd be surprised. Sometimes you open up and you can do radical excision. So these were the pre-operative, and I had no clue that I can do radical excision. I just went for. I was hoping if I can do just partial removal, but I have done a very good job. I have done total resection, because it really, by patience and by dedication to your work, you can achieve good results. Excuse me. Again, this case again looks like formidable, but before and after surgery, you have achieved a good result. Same here, a large giant one. Same here, before and after. We do MRI the very following morning. We don't do CT as post-operative follow-up. MRI on the very first day. Again, here, this is the case which I mentioned, this 47-year-old female professor of English language in the University of Jordan. And again, it looked like impossible to treat. We've achieved a good result here, as you can see. Recurrence, one of the cases of recurrence, 38-year-old male patient with this extensive tumor, pre-op and post-op, and then he had recurrence 7 years later, for which we gave gamma knife radiosurgery. So this is a very good example of using the gamma knife in a very reasonable scientific method. Steps of surgery, I'll take you through still pictures in my series. Drilling of the greater wing of the sphenoid. You have to open the sphere orbital fissure. These are still pictures from my cases. Having done the drilling extradurally, you open the dura and you come to the tumor. In this case, the tumor was encasing the middle cerebral artery branches. In this case, it was surrounding the A complex. So you have to be patient and remove it from there. In this case, the anterior clinoid meningioma was sitting here. It's anterior clinoid, this is optic nerve, and this is middle cerebral and anterior choroidal artery. So the tumor was engulfing these results, as you would expect. So again, by being patient, knowing your anatomy well, the basics of skull-based surgery is anatomy that you have to master. If the tumor is involving the optic canal, you have to open it up. You have to drill the anterior clinoid intradurally, you do it. So this is the last piece, and disconnecting it from the optic strut. And then the whole roof of the cavernous sinus, where the clinoid segment of the internal carotid is there, and you can see the distal ring and the proximal ring. If there is involved dura, you have to remove it, achieving Simpson grade 1. Here you are following the arachnoid plane around the oculomotor nerve at the edge of the tent. Here you are opening the optic canal. So this is the optic nerve subarachnoid segment. Here, this is the optic canal. Opening the dura around the optic canal. drilling of the anterior clinoid medial part, following every segment of a tumor that goes into the canal. And you can actually see the ophthalmic artery and see that the tumor was going into the canal with the artery. So being patient and doing your job, you can come across this beautiful result where you have preserved the nerve, the carotid, the pecum, the anterior choroidal, sphenoparietal sinus, superficial middle cerebral vein going to the sphenoparietal sinus and the lateral wall of the cavernous sinus. Just clips of the thing and we are finished. I just
Can you see the video?
can you see the video?
No, not yet.
No, we can't see it.
Okay. Can you see them now?
Not yet. Just play it as if you were playing on your desktop.
Yes, yes, just give us a second.
Yeah, and then screen share.
For some reason, I can't find the. For some reason, we can't play it. I'm
Okay,
not sure.
that's
the problem.
It's okay. It's okay. No problem. We're gonna have Professor Rahim and URC. I just want to say this was an amazing session. I really am so proud of what I saw here. Generations apart, Asil gave an amazing, introduction to the anatomy, and then Professor Sabayh gave us really what an experienced skull-based surgeon does with care and with attention to detail. So this was really educational, and it was great. As we are a family, Asil, you and Ibrahim, since Asil gave the anatomy and then Professor Rahim showed the anterior clinoid tumors, I'm going to take a couple of minutes just to show the vascular aspect of this. As I was listening to you, I was thinking, you know what? We have to complete the family thing here. And
sure.
So let me, so what Asil was talking about, so this is a view from the right side. So right terional approach. So you're looking through the sylvian fissure. You have the right optic nerve to the right frontal lobe and the right temporal lobe. So I want to show you some technical issues from a vascular standpoint that are very important for what Asil was talking about. See, this is me opening the dura on top of the anterior clinoid. So the way we do it, we cut the dura in this elliptical kind of way. Now, there are people who cut the dura this way, and I respect that, but I believe this is a better way to do it, and I'll tell you why. The reason is once you open the dura this way, you reflect it this way, you're covering the optic nerve and the carotid when you're drilling the anterior clinoid. But if you are cutting it here, you don't have protection of the dura sitting on the back part, okay? So that's a simple technical point. In this case, there is a aneurysm here sitting underneath the optic nerve, but that's a technical point I want to raise. So you see very sharply cutting this, okay? Like that in a round way. Then you use a dissector and reflect the dura backwards, just like Asil was showing and the professor showed in his slides as well as to how to expose this, okay? So this is how you see that, how this dura helps me protect the carotid or putting the dura on top of the carotid. Now the drilling for the junior, neurosurgeons and residents, two technical points are very important. Number one, do not have a cottonoid sitting right next to you here when you're using a drill. the drill can suck the carotenoid and can cause an injury. Secondly, you should never have a drill on without irrigation going at the same time at every step of the drilling. The reason for that is the drill causes heat, and the heat can be transmitted to the optic nerve. So it's very important for you to have irrigation going as you're drilling in this area or any area in the skull base, anterior, posterior clinoid, the condyle, around the vertebral artery, same lessons, okay? Never have somebody else have their foot on the pedal while you have the drill on. The drill, your hand, and is your foot. I know some surgeons like to have somebody else, okay, on, off. Big mistake, something bad can happen. You should have in control. When I'm doing this part, my left hand is a suction, right hand is a drill, my foot is on the drill, on the pedal. No one else in this situation, because that is a risk for disaster, okay? So these are just technical points I wanted to raise. You see how much irrigation there is here? Even when you see smoke like this, it's not a good idea. You need to have really enough irrigation going on at every step, as you see here, okay? So you get a little bleeding, no problem. You got a little bit of cavernous sinus bleeding. It is no problem at all. You put a little Surgicel or now what Asil was talking about is a distal dural ring. You want to cut the distal dural ring circumferentially, okay? In this case, there is an aneurysm, and part of this aneurysm is extending into what I call the sphenoidal segment of the carotid artery. But in this case, the distal dural ring is actually around the aneurysm itself. Okay, so I have to cut the ring around the optic nerve and the aneurysm itself. Sharp cutting, do not pull here, okay? Now, technical point. You always cut the ring from here this way. Don't ever start here. The reason is the two rings are separated up here and they meet down here. The minute you cut the ring here, you're gonna go through the proximal ring. It means you're entering the cavernous sinus, which is okay, but you need to be aware of that fact, okay? So you will see how I do this here. I know I'm cutting close to the cavernous sinus because the proximal ring will meet here, but it's separated here. So the two rings are like this and like that in this axis. So as you come closer to the proximal ring, you will get cavernous sinus bleeding, which is totally okay as long as you're aware of it. Because I do need to get around here because this aneurysm does extend into the cavernous sinus, okay? So you see this is a carotid and that's the aneurysm here, okay? Very similar to what Professor was showing, but this is from a vascular standpoint, just to complete the lecture for you completely, you could see it from both perspectives, the tumor surgery and the vascular. You see how it started getting some bleeding? That means you're starting to cut into the proximal ring. The minute you see this bleeding, that means you're cutting the proximal ring, which is okay because you're gonna keep putting Surgicel or whatever. But see, this means you just open the proximal ring. That is where the two rings meet, and so it's an important technical point to you see how I'm getting this bleeding. Fine, I know exactly where I am. Now you see it's happening. This aneurysm is half in the subarachnoid space, half into the proximal ring space here. Okay. So this can be a little challenging, so you have to be very careful from that perspective. I just need to have enough ring cut for the clip to slip underneath in the neck of the aneurysm here. So this is just the points that Asil was talking about and the professor was talking about that are technical and very important from the perspective, okay? And as you see, I don't use retractors. The retractor will get in my way here. You see, it's very smooth, so I don't have to use that at all. Okay, so you see now I'm comfortable that I've got underneath to the neck of the aneurysm here. The whole anterior clinoid is removed. The distal ring, the proximal ring are meeting us right here. Okay, and that's fine. So here you see how this patient was losing their vision. The optic nerve is all the way stretched up, just like tumors do. Okay, I'm being very careful. This patient presented with progressive loss of vision. All right. That's why this was not a case for endovascular treatment. This had to have a microsurgical treatment. And you see, that's the whole dura right here. Okay. And that's the aneurysm. Now I'm all the way down here. Okay. Now you see, I have to get underneath the aneurysm here. Okay. Now, I'm just making technical points. If you're a very experienced surgeon, that's fine. You could be doing this. If you're not, and you're doing this early in your career, you need to have proximal control of the carotid in the neck before you do any maneuvers that I'm doing here, okay? So it's all curve of experience related, these maneuvers, okay? So all of us have to gauge that, all right? So that's a carotid. I'm hoping to be able to get a clip on the neck just along the carotid here because I've opened enough of the proximal ring. So let me put the clip and see what happens, okay? As far as I can go, all right? What happens, you see the aneurysm is filling. That means it's not enough. The clip is not far enough. This is a very wide neck aneurysm, okay? So what do you do now, okay? Don't do anything crazy. Don't start pushing it, okay? You need to get circumferentially more before you do anything else. So, you know, I use this under very low bipolar. I shrink the aneurysm to get circumferentially around the aneurysm. Again, for the more junior neurosurgeons, I would not be doing this unless you're very experienced in peripheral aneurysms and MCA aneurysms and doing this kind of thing. But as you get more experience, this is a great technique, okay? I want to decompress the optic nerve and I want to get underneath the neck of the aneurysm. You see how now I'm trying this other clip just on top of it and see if I can get all the way across since I have shrunk the aneurysm by about, again, you see, it's still filling the aneurysm, okay? What I need to do now is get completely this portion decompressed of the optic nerve and reflect this way, okay? You see, now I'm all the way across the aneurysm. The optic nerve is really released at this point. And that allows me to get all the way across here on top of the carotid and completely encircle the aneurysm, just like that, okay? Now I'm very comfortable. I can remove these other clips, all right? So these are the, you know, and so this is the ICG. You see the optic nerve, the aneurysm is gone, and showing you the complete clipping of this aneurysm. Let me just show you one more case very quickly, and then we can go to questions, okay? Just to show you this anatomy that's so well presented by Asil and the professor, okay? This is a wide neck aneurysm, grade 1 subarachnoid hemorrhage. They tried to coil it, the coilant wouldn't stay, okay? So they asked me that I have to do something. So you look at the anatomy here that Asil talked about. You see, the aneurysm is embedded inside the anterior clinoid, actually embedded inside the anterior clinoid. Now, this is a high-risk case. This is not like other ophthalmic aneurysms where the aneurysm is on top sitting here. This aneurysm is inside the bone. Now, if you see this finding, and it cannot be endovascularly treated, you have to reach deep in your soul and figure out if you're comfortable drilling the bone that is attached to the aneurysm. If you're not, perhaps call someone who would do that, okay? Because this is a very dangerous sign that you're looking at here. When a vascular lesion is embedded inside the bone, that means if you're gonna get around it, you're gonna be drilling on top of the aneurysm. So these are, I'm just for my colleagues, the younger colleagues, just giving you some pearls and lessons from things we have learned over time, okay? So as you see in this reconstruction, the anterior clinoid, as Asil talked about, the optic structure is gonna be here. You see the aneurysm is all embedded inside the bone. Unfortunately, they were not able to coil this aneurysm. They were not able to stent it because it was a fresh rupture, so you cannot anticoagulate the patient. So put me kind of in a difficult position when they sent me this patient, okay? But let's look at this together, okay? Let's really decide how we're gonna handle this situation. All right, as many of you know, like the last case is this case, I do all these surgeries awake so that I can test the patient when I'm doing very specific steps, okay? So this patient, I'll show you in a minute. See, this is now we're from the left side. So that's the left frontal lobe, left temporal lobe, sylvian fissure. I'm coming down at the anterior clinoid area. You see, this is the aneurysm inside the anterior clinoid, and I'm drilling on top of it with a drill. Again, you know, this is something, unless you really have a lot of experience, you ought not to be doing until you get to the stage which you have done I would not have done this. In my earlier vascular career, I would not have been doing this myself. But you know, once you get to a level where you've done hundreds of aneurysms, okay. Now, you see what I'm doing? Again, this is a distal dural ring right here. That's the optic nerve right there. Asil showed this anatomy very nicely, and Professor Subayh showed us this as well for anterior clinoid meningiomas. Okay, so this is opening the distal dural ring. Problem is that's not going to be enough in this case, as you notice. The whole aneurysm is embedded inside, but optic nerve, carotid artery. Now I'm going around to get to the proximal ring and to look at that as well. Now I have to drill in front of the anterior clinoid, in front of the aneurysm itself. So that's, you see, that's the aneurysm dome. That's the bone is completely encircling it. Now I'm opening the proximal dural ring to get all the way around. See, optic nerve, aneurysm, the distal dural ring, the proximal dural ring. Again, that relationship I talked to you about before, okay? To be able to get to the neck of this aneurysm, all right? So that's a band from that's the internal carotid artery coming in intracranial. So the anatomy we're talking about today, anterior clinoid, this really shows everything about it so that we're all together. And I hope I'll be doing lectures with Asil and Professor Subayh together in the future. This is a nice combination, okay? So all the way around, so we're underneath the optic nerve here, okay? Now, what can we do? You see, that's a carotid, right? That's the aneurysm, but I'm not, now I have to do something really, again, the problem is I'm not all the way across the aneurysm. The bone is still stuck to the front part of the aneurysm. So now I have to drill on the anterior part of the aneurysm right here, okay? Right there, okay? So what you're seeing is, this is exactly what we're doing, okay? And you're drilling, just a technical note, drilling in anything inside intracranially is not about pressure. It's very light. Your hand has to be very light. If you're tense, you're not doing the right thing. Your hand has to be so light that I'm almost feeling the vibration of the aneurysm as I'm doing it. If I'm being tough and trying to hold my hand really strongly, that's very dangerous, okay? It's counterintuitive, but it is the right way to do it, okay? And now we're all the way around. Now I'm shrinking the aneurysm, okay? To be able to get a clip. And now I'm opening the ring further here, okay? And now the clipping is going on from that standpoint. You see some blood from the, so that's the anatomy we just talked about today. And that's a complete clipping of the aneurysm there. So, so we thought we just cover with you some of the technical points that are important together with all three of us. We kind of circled the whole anatomy from every direction. So that was very nice. And this will be memorable for me. I will always remember this.
Me too.
Yeah, this will be very memorable, very, very memorable. It was a lot of fun.
I wanted to ask if we can try and share the video again, just, you know, just to make sure that we have.
Yeah, please go right ahead.
Let's try. Can you see it?
Yes.
So again, this is showing, thank you, Salim, for this very important addition, showing the vascular point of view of dealing with the lesions around the anterior clinoid process. I'll just jump. So this is the way that you are dealing with these tumors once you go through the terional approach. Even if you see the vessels were encased pre-operative, just being patient and trying to find the plane of cleavage, you may succeed and make miracles, actually. So this is a piece of a tumor which is attached to the tent and attached to the third nerve. And you can see here the carotid artery and the pecum and the anterior choroidal. This is the middle cerebral. Again, here, as I said, important part, in addition to the drilling of the anterior clinoid, is to open the superior orbital fissure, because this is the only guarantee way of getting rid of the exophthalmos, if there is one. Superior orbital fissure must be opened, and you cannot do that unless you cut the meningioorbital band. So essential part, the drilling of the anterior clinoid, and as Dr. Abdurraouf said that, Professor Abdurraouf said that, you have to be light in doing this. Opening of the superior orbital fissure. Here is drilling of the anterior clinoid. This is the last piece of the anterior clinoid and the dural rings that you see. Here we are cutting this distal ring here because the tumor was attached to it. And here opening the arachnoid plane around the oculomotor nerve. This will get you some distance and you can mobilize the oculomotor nerve. Here is the deroofing of the roof of the orbit of the tumor was there. Opening of the optic canal. Opening of the ligament and then proceeding here. I said you have to pursue Simpson grade 1. Medial or lateral to the optic nerve, follow that up. Here you can see the tumor going with the ophthalmic artery through the optic canal. You just cannot leave this. You have to drill it. It will add some time for the surgery, but this is skull-based surgery. It's time consuming if you are doing a job properly. So drilling, even if the tumor is going into the sphenoid sinus, you follow there and you pack the sphenoid sinus. If you open the anterior clinoid and it was pneumotized, you have to pack it. So it's the culmination and the summation of the good anatomical knowledge, the cadaveric dissection, and the surgery practice. You drill with the side of the drill, you then drill with the tip of the drill. Here, this is again a triennial approach to this anterior clinoid process, and this is particularly to show you the sphenoparietal sinus and the superficial temporal superficial middle cerebral veins going into the sphenoparietal sinus. Some people would report disastrous sequence of cutting the junction of the superficial middle cerebral vein to the sphenoid sinus. Some people would actually sacrifice it without much of results. So just move on to show the pertinent facts that we mentioned about this tumor here. You are finding a good plane of cleavage around the internal carotid artery. The tumor surrounding the middle cerebral arteries and the cerebral artery branches. Here is the sphenoparietal sinus going into the cavernous sinus. Here's a very complex tumor which really was tough. This is the one I told you when I saw the images, I thought there will be no plane of cleavage, but by perseverance, by dedication, you don't look at the clock in the operating room. There is a job you want to do, and this is the first time, is the best time for the patient to achieve Simpson grade 1 or 2. So going around the tumor, finding plane of cleavage, remove it from the branches of the internal carotid artery, be it anterior choroidal or pecum, or even going into the posterior fossa. You have to follow the tumor and take it out. Here is the stalk. And you can see here the pecum and the anterior choroidal artery. We are separating the tumor from them. Following the tumor into the posterior fossa. Here is the tumor surrounding the acum area. We always preserve the olfactory tract, whether it is interhemispheric approach transbasal or pterional. I always make it a point to preserve both olfactory tracts. I believe olfaction is a very important thing to preserve. Piece by piece. This is the chiasm here. So having removed the tumor, last piece with the dura must be removed. This is the best chance for the patient. The first time there are no adhesions, no radiation adhesions. So we have to do that very well. And this is where the origin of the tumor was, extension of the tumor. So we have to take it out completely. Excise that dura and give the patient the best chance possible. I think with this I finished, and I thank you, Professor Abdul, for being with us. Thank you for your contribution. It's a great pleasure for me and for Asil to be with you tonight.
Yes, it was a great pleasure. Thank you, everyone. Thank you, Professor, for all the kind words you have told me. I'm sure it will give me a huge push to continue on. Thank you.
Thank you. We're proud of you, and we look forward to future collaborations. You know, we are really trying to support women in neurosurgery to really in this field. So you represent an important part, and so I'm sure some of our clubs around the world, Asil, will be contacting you to be involved with them. I look forward to you mentoring others who come after you, because that's a responsibility for all of us. Thank you.
Sir.
Amazing opportunity. Ahmed, I want to turn it back to you.
Thank you, Professor Salim, and thank you, Professor Spray, and to your Asil. I want to just invite the attendees in order to show you some amazing things. Okay. Can you show that? Can you see this?
Yes.
On behalf of Professor Salim, of course, if His Excellency permit me, inviting all you to join and to attend or even participate in our Congress in Granada, in Spain, in September of this year.
Yeah, thank you,
Ahmed.
Ahmed. This is very
Salim?
this is very important. You know, this is our mentorship model. So we have mentorship for the next generation of neurosurgeons. This is, we're going to have students from countries around the world who are entering the field of neurosurgery. They're going to be coming to Spain, and neurosurgeons and residents serve as mentors. So this is part of our University of Neurosurgery mentorship program. And they have put together an amazing program. It's all the officers, the students from Germany and all over Europe, have gone out of their way to create this for our University of Neurosurgery. And it's a platform for neurosurgeons to serve as mentors to students all over the world. Okay. So I hope I will see you guys there. We look forward to to contributions from all of you as mentors for the next generation. Thank you, Ahmed.
Okay, thanks everybody. Let me just say one parting word before thanks to Sabayas.
Sorry, I have some problems with connectivity.
Oh, okay. So, okay, Abdul, I'm just going to talk about this conference tomorrow morning with John Adler presenting about his platform, Curious.
Okay, John.
Okay, you can't hear me? You can't hear me? Can you hear me?
I share something else?
Okay,
John.
Can you see this share at all?
Yes.
Yes.
Yeah. We see it.
Okay, well, just briefly, it's tomorrow at 9 o'clock Eastern Standard Time. We hope to see you there. Go ahead, Ahmed. Go ahead, Ahmed.
Just a minute. I want to just share something else. Okay, you can just talk.
We don't see your share, Ahmed.
Yeah, he's doing it
I'm
from a
so searching
smartphone.
for it.
I'm not seeing
Yeah.
it. You're doing it from a
I'm sorry.
smartphone, right?
Meanwhile, we have somebody who has her hand up. I just want to give a minute to Zahra Adam. Can you speak?
Yes, can you hear me?
Yes.
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 So I'm Zahra Adam, a fifth-year medical student at University of Jordan and Jordan University Hospital, and a very proud student of Prof. Dr. Subeh. Prof. Dr. Subeh, after your permission, please, I would like to express our admiration on behalf of the medical student of University of Jordan. And here with us is Dr. Sumaya Kaswani. She's an internal doctor, and Dr. Faras Abu Hajla, he is an orthopedic surgery resident. I just would like to express our admiration and how much we are proud to have such as the clean heart and brave soul, smart and elegant female neurosurgeon, Dr. Asil Subeh. Dr. Asil, you actually left a great impression in our field by the Prof. Dr. Subeh. He is my mentor, he's my idol. And from both of them, we learned more than just neurosurgery. So thank you so much.
Thank you, Zahra.
Thank you,
very
Zahra,
much.
for your kind words. Thank you. I appreciate it.
My pleasure.
Ahmed, are you able to do it or not?
Go ahead, Ahmed.
Okay. Okay, just a minute.
Sure.
I will share it directly.
You're doing this from a smartphone. It's not easy.
Yeah. It's very.
There you go.
Who is this good-looking guy here in this picture?
There you go. That's Ahmed.
Yeah, who is this guy?
Can you see my screen now?
Yes.
We see your smartphone. Yeah.
Yeah.
Yeah, this is an invitation for the 40 Yemeni conference in May. This conference will, will be included with many neurosurgeons from around the world, like Professor Sani Abdurraouf, Professor Bram Subeh, and Al Mufti. Many great neurosurgeons will be included. Okay, it will be streamed with the neurosurgical TV, as you see in 22 and 23 of May. Okay.
Very good.
That's great.
John,
Okay.
there is Dr. Jabir raising his hand for a question.
Yeah, okay, go ahead, Dr. Jabir. Can you hear us, Dr. Jabir? Dr. Abawi? I see his hand raised, but I don't think he's in the panel, actually. So, okay, I guess we're gonna have to close. So thanks, everybody.
Thank you, John.
See you-
Thank
see
you.
in a
Thank you,
bit.
everyone. Thank
Thank you.
you. Thank you.